Vascular events, necrosis and dissolving. Over the next few slides I'll be talking around vascular events, necrosis and dissolving, how to use hyaluronidase, how to stop things developing into necrosis, and how to spot when you have a vascular event such as an occlusion or a compromise actually happening. So we're going to start off with vascular compromise. Now, you may call this vascular occlusion or vascular damage, but basically this is where dermal filler has been injected into a blood vessel. Think of a Smarties tube as the blood vessel, and the dermal filler has been injected into the Smarties tube rather than around the Smarties tube into the tissue of the lip. That is literally what it is. Now, there's a massive clock on the screen just there, and that is because time is important. And as a practitioner, you have to be quick as possible to spot when there is an issue, because early recognition and treatment is the most important thing when a vascular compromise happens. Now, I call it a vascular compromise because what I don't know is whether the dermal filler is inside the Smarties tube, i.e. it is inside the bloodstream, or whether the dermal filler is on the outside of the Smarties tube, squishing the Smarties tube so much that the blood isn't able to flow through. But either way, the blood has been compromised, it has been squished and stopped in some way, and that means that the blood is not able to flow through. If the blood's not able to flow through clearly, it means that the blood's been affected. And that means that the tissue around it is going to start to die. And if the tissue around it starts to die, it'll start to die off, and that'll be turned into something called necrosis, which I'll come on to shortly. Early recognition is the most important thing, and that's what is needed here to stop anything, hopefully anything negative happening to the tissues around it. Now, you need to spot this as quickly as possible. And people always say to me, James, what can I do to stop this from happening? Because there must be something. And you're right, we do lots of things as practitioners. We inject slowly. We use very fine needles. We use cannulas. We do things such as aspirate on needles, for instance, to try and see if we're in blood vessels. And all of these things that we do help us to reduce the risk. But the most important thing that we do out of everything, no matter what it is actually look at the person. Look at the person beforehand, look at the person afterwards, and see, does the skin look the same before and afterwards? Does it look fit and healthy? Can I squish the skin? Can I let go of the skin? Does the blood flow just the same before and afterwards? Is the capillary refill check. This is where you push firmly on the area for a few minutes and then let go. Is it the same before and afterwards, or is it different? Okay, this is what a vascular compromise is. This lady here was one of the very first ones that I helped a colleague of mine with. Now, my colleague had been treating this lady. She's had her top lip filled beautifully. There's a fabulous picture this. We only took one picture, and this was the only picture we took. And had I have known several years later I'd be doing a presentation like this, I'd have took a lot more pictures, probably a video, and that's what I would have done. But as I look at this picture just here, I can see a beautiful top lip with some lovely dermal filler in. She's had some filler put in. I think at the time they were using a filler called Princess, which is made by a company called, an Austrian filler called Safer Now, made by a company called Chroma. And she's had some filler put in the bottom lip as well. And you can see a very large white patch on the lower left bottom lip. And this white patch has been caused because a blood vessel has been affected. Now, as we sit and look at this lower lip, what I'm aware of is that a blood vessel has been affected. And the blood vessel that's been affected is probably the lower labial, which is often referred to as inferior labial artery. Now, running up the face, probably somewhere over here where I'm drawing on the face now, is the facial artery. And it runs up here, something like that. That's roughly where it goes. Maybe a little bit off just there, but it's to give the example of roughly where it goes. And of course, the blood is flowing in this direction. So that's the direction that the blood flows, the direction the arrow is going. And of course, it branches off and it goes across here and it nips in the bottom lip, and it branches off over here, and of course it goes into the top lip, just like this. And this top branch is called the superior, and the bottom branch is called the inferior. Now everyone is different what they look like, and this is an example which this client could look like. Now we can see from where this white patch is just here that it wouldn't be surprising if this lady's blood vessel actually looked like this, because we can see that there's a white patch there. So it may be that their blood vessel there has been affected. So you can see a very clear occlusion on the surface of the skin. Now we tried to massage this first of all. We give it a very good massage, that didn't help. We tried to tap it because we thought if we tapped it we could maybe dislodge it. So tapping maybe is a bit of an old school of thought, but not too old. It's not too outdated. It's still something to consider. So we tried to tap it and tap it to see if that would help. It didn't completely, but we did try. We also tried to deep tissue massage rather than just gentle. We added some heat. We made her a brew. Very simple technique is to make someone a warm drink, warmed up her mouth, would warm up the blood vessels in the area, help them dilate, and we got some warm compress on there as well, with a warm cup of tea and some warm paper towels to try and warm up the area. Unfortunately, that didn't help either. So we had no other option but to dissolve this filler. Now, we mixed up some hyaluronidase and it actually very, very quickly dissolved. We weren't surprised at that. It dissolved very, very quickly, and we actually dissolved the filler in the lower lip, and it went. Unfortunately, I didn't take any more pictures. This was several years ago, and we weren't quite taking pictures quite the same way that we take pictures today. We reach for our cameras a lot quicker. At the time I'm recording this, far quicker than we were at the time that this happened in the clinic. The lady was absolutely fine around it. We explained what happened. The bottom lip dissolved very quickly, and then we dissolved the rest of the actual lips for her as well. Unfortunately, I just happened to be in the clinic supporting my colleague, but my colleagues did tell me that the lady popped back a few days later just for a check, and she was fine, and she actually came back around 2 to 3 weeks later as well, and successfully had her lips filled as well. So she had some filler put in her lips 2 to 3 weeks later, which was also very successful without any incident. So she was very, very lucky. But there's an example of what one looks like, and you can actually see which blood vessel has been affected as well. So what is a vascular occlusion? Well, normally there's some pain when someone has one, but that's not always the case, because often clients smother their own lips in numbing cream beforehand, or you might have given them some numbing cream, or they might have had a dental block, for instance. There may be some white patches of skin, like blanching of the skin, which you saw on that lady just there. There may be a slow capillary refill, which is what you saw on my lady as well. So where you've pressed firmly on the skin and let go, it might take a while for the blood to return. And after a few days, the skin starts to go bluey, grey, even 24 hours. And that's because the skin starts to die off. And that's because there's no oxygen there. And we call that deoxygenated area. And that's the start of necrosis. Now, I've got another lady here. This isn't one of mine. This is actually quite a well publicised one. And this lady's got a very white looking nose. And it looks to me like she's having nasolabial folds done, if I had to guess. Because her nasolabials look different from one side to the other. And if you actually look, her nose is white, and half of her cheek is white as well. It's completely blanched under her eye, and it actually spreads right up her nose into her central forehead. The glabella, particularly the procerus muscle in between the eyes, is white. A lot of her top lip is white as well. Now this is probably due to this blood vessel here, which runs up, being affected again. So somewhere up this main blood vessel. So rather than it being one of the branches which comes off this time, it's probably the main branch itself which has been affected somewhere, rather than one of the branches which come off instead. It's just quite a well publicised one. She actually was very, very lucky that it didn't cause any long-term problems for her. But this is why, and I mention this to people, that it's so important to take as much makeup as possible for your clients off their face. So remove as much as possible, take the makeup off the face, the nose, the forehead. Even if you're working on the lower face, it is so important to do that because you don't want to miss anything. Like if you were just doing her lips or lower face and left her makeup on her nose, you might miss that nose changing colour, and that's why it's so important to take as much makeup off as possible. This is another quite well publicised lady's lips, which I think appeared nearly everywhere, and this was several days later. When we're looking at her lips, we can see her central lip is black, and we'll circle around the black area here. So we can see this awful black area in the centre. And some people might go, do you know what, that's just a bruise. And do you know what, if it was just on its central lip is black, and we'll circle around the black area here. So we can see this awful black area in the centre. And some people might go, do you know what, that's just a bruise. And do you know what, if it was just on its own and just on the lip, you might think, do you know what, that could be maybe just a bit of a bruise or a bit of a problem. You never know, could be something like that. You know, if she'd maybe had a problem afterwards, or she'd bled quite a bit. Having it done, you might be thinking, is it, isn't it not? That's what it could be. Possibly, possibly. When you look at the lower lip, you start to realise that all of this area underneath now is all mottled round, and she's lost definition in her lower lip area. The area is started to become, probably got some infection, probably got some problems with which has lost the definition of her lower lip. You can't see where her lower lip ends, and we go into the skin of her chin area, moving across to her chin. This is all starting to die off as well. You've got central necrosis now in the central region, and you've got a major problem going on there. That needs dissolving. She needs some antibiotics. She probably needs some steroids to treat that. This is necrosis several days down the line, causing major problems for this lady. This isn't just a quick fix. People say to me, like, how did the practitioner miss this? Was it the practitioner's fault? Was it the client's fault? And if this lady came and seen me, that would be like the least of my worries. Most important thing, let's get it sorted first of all. Let's get it sorted. And then what we can do is have a chat with the client. Let's educate the client on what it is, first of all, so they know for the future. And then maybe let's educate the practitioner, because if the practitioner doesn't know what it is, rather than blame, let's try and educate and say, this is what it is, this is what we need to do. And if you know what it is, it can try and prevent it from happening next time. Because the practitioner may have not seen it on the day or been aware of it. That's one of the things. So it might have looked completely normal on the day. And actually when the client went away, the client might have thought it was just some bruising. And actually it's just got worse and worse and worse. And not until now that I've thought, ouch, there's a major problem here. This is really sore, this is really problematic. Can't feel my lip. I need to get it sorted, and it's several days later. Okay, so what is that necrosis? Well, probably the most severe and feared thing for us as aesthetic practitioners. major interruption of the vascular supply, major problems with blood issues, and basically it's the death of tissues, and that's the problem with it. You know, incidence rate probably relatively low, 1 in 100,000. More likely with novice practitioners who are new to aesthetics rather than those who are more experienced. If you are new and you're watching this for the first time, contact someone who's more experienced for advice and ask them what they think. So, what would we do around dissolving fillers? Well, there's a whole section on hyaluronidase, including guidance, a video to watch. I've done an elective video as well with some dissolving and a patch test. So please watch the videos. But everybody, no matter who you are, where you work, what you do, needs to have some of this stuff in stock. This stuff is called hyaluronidase. And hyaluronidase is basically filler dissolver. It dissolves down filler. It's the stuff which makes filler disappear. And you mix it up, you inject it into wherever the filler is in the face, and it dissolves it down and it actually gets rid of it. Now, hyaluronidase is officially an enzyme, and it's not actually designed to get rid of dermal filler. It was actually designed to help fluids move around the body, really. That's what it's actually officially used for. But it does actually help to break down and dissolve dermal fillers. That's what it can be used for. It actually comes from the testicles of sheep, so it's classed as ovine, meaning from sheep. It doesn't really need to be stored in a fridge, but it's best stored cool, so don't put it in a warm room. I always suggest to people stick it in a fridge box, like a Tupperware box. You know, get a butty box, get a clean, sterile, new sandwich box. Put your hyaluronidase in there, put your needles, your syringes, your guidance, your consent form, fold it all up, stick it in a Tupperware box, put the whole thing in a fridge where you work, and then when you need it in an emergency, you can just go and grab the whole thing out of the fridge and you've got the full shebang ready to go. You should use whatever you need to use and then get rid of the rest. Don't save any, to use and get rid. That's the advice. So it's hyaluronidase. The branded version is called Hyalase. And it does vary in price. I've seen it as little as £15 per vial, and more recently as much as £75 per vial. So it does vary quite a bit. It is I should have said it's a prescription only drug, so it has to be prescribed. Now, I have done a video, so please watch the video on how to mix it up. Anywhere from 1 to 10 mils of liquid tends to be recommended. Bacteriostatic is what tends to be mixed up with. Bacteriostatic 0.9% saline, which is also a prescription medicine. And we tend to inject it with something like these insulin needles, which you'll see on the screen, and they tend to be 27 to 30 gauge insulin needles that are used. So make the most of those and use the 27 to 30 gauge insulin needles to inject it in. So we probably should be doing a patch test as well, but only in routine dissolving, not in an emergency case. So when it comes to if there's an emergency occlusion, you just want to jump in and dissolve. But in a routine case, so elective dissolving, you probably should be doing a patch test. If you watch the video, which is on this page here, you'll see an example where I do a patch test on an arm, and you'll see that the patch test is negative before I proceed with the dissolving as well. We're just injecting a very small amount, a few units into the actual arm before going ahead with it. Now, probably true anaphylaxis to hyaluronidase is probably unlikely, exceptionally unlikely, but there's no harm in doing it if you feel it's appropriate.